Great. It has been such an exciting conference so far, and I know you guys have all had a number of really interesting and thoughtful questions that have arisen over the course of all these great presentations we've had. And we have been monitoring them as much as we can in the Q&A window and in the chat. And what we'd like to do during this period of time is take some big themes from those questions that you guys have all been asking and pose them directly to our experts. And then after we kind of go over some of these big questions, we'll open it up and allow you guys to ask any questions that you have of these experts in the second half of this period. And just to remind you of who this incredibly talented panel of experts are that we have here. These are the presenters that we've had over the course of the presentation here. And we have invited them all back to be able to answer your questions right now in real time. So to start, there have been a large number of questions about the idea of genotype-phenotype correlation, or what that means is how does the actual genetic cause of each individual's Kleefstra syndrome correlate to how their syndrome presents itself and the symptoms they have. And people want to know, they want to know what the differences are in between mutation events versus deletion events, in between the EHMT1 versus the KMT2C types of Kleefstra syndrome. And I think most importantly, what people want to know is, how can I take the genetic information I know about my individual's Kleefstra syndrome and translate that to something meaningful about their prognosis, their disease progression, or the type of care they should receive.
I was muted, sorry. I think that relates to what we discussed. So at a general level, there is this difference. So if you compare groups with deletions to groups of individuals with intragenic EHMT1 mutations, then in general, on all aspects, you see more severity in deletion cases, but that does not necessarily account in the individual person. So also in my experience, I know individuals with intragenic EHMT1 mutations that are quite severely affected, mainly on developmental aspects compared to a person with a deletion. So at the individual level, it's still very difficult to look in this glass bowl for progression and future aspects. Within the group of deletion sizes, in general, the larger deletion, the more disability is seen, both developmentally and somatically. So persons, and they are not so common, that's really rare, but who have over 1.5, 2 or 3, even 3 MB deletions, they are most likely more severely affected than individuals with a smaller deletion or with EHMT1 intragenic mutation. But also again here, I think so far, we in the Netherlands have studied this at most. As I mentioned, we have 70 million people in the Netherlands, so the number of cases is still quite small. And from what we know, also what is published in literature, this is the general aspect. So at the individual level, just still it is you need to look at the individual capacities and check for mental issues as mentioned, so that you don't differentiate between deletion or mutation cases. But the larger the deletion, and especially over, well, as I mentioned, the 2 or 3 MB, there's also other what we call OMIM genes, so genes that are known to be associated with human diseases present in such a deletion. So yeah, geneticists should be carefully look at those genes and act consequently for clinical care. I'm not seeing anyone. I'm not sure if if you all are listening, but I only see a screen with photographs. Yeah, there I see Maya.
Guess I would add from the cellular side, this is Liz Buttermore here, that we do see differences in the phenotypes of neurons coming from patients with point mutations in EHMT1 versus larger deletions. So it is possible that we may need to look at phenotypic screens or compounds or relief that are different for the different populations because of that.
Great, thanks, Liz. Does anyone else want to add anything to that question? Could you speak, perhaps this is again best for you, Dr. Kleefstra, to the differences in the presentations of the EHMT1 versus KMT2C types of Kleefstra syndrome?
Well, we are currently conducting a study. We are collaborating with the team in Manchester in the United Kingdom, where we have collected many cases with KMT2C to look for the commonalities in that population. But that study is not finished yet. In general, there is some overlap, but it's with many neurodevelopmental disorders. That's on the developmental delay, on the behavior problems, some less prevalence of medical problems, somatic problems, but it's just too early to be really clear on that aspect. But also physically, these are different disorders. So yeah, so what I commented during my presentation, it's really designating the Kleefstra syndrome type 2 is not the correct way that OMIM should do it. And I sent already several messages, and also the Kleefstra.org Foundation, they have not been mentioned so today, but I think Fiona and Chris from UK have done really important work for the Kleefstra community already for quite some years. And they also try to contact the OMIM managers to really rename that, because it's really, I also see patients in our clinic that are referred because they have Kleefstra syndrome, and then we look in the results letter and it's KMT2C and it's type 2, but it's really not what we what we support. So it really deserves an individual entity, because it's very confusing. But there will be clinical studies on that syndrome. We are doing that, but we have not finished yet for the complete analysis. So I hope we can have some more information on that disorder in near future.
Great, thank you.
It's good. Maybe if I can add, I mean, completely agreeing with all the clinical comments, obviously, of Tjitske, but from animal models, at least, we do see that there are functional relations between these genes. So it doesn't make them the same entity, obviously not, but it does make them prime candidates for whatever we would find, for example, scientific hypothesis, but also potential interference at the level of pathways. So I'm not talking now about gene therapy or so, but if we would find any ways how to alleviate problems basically by manipulating pathways, then these would be prime disorders. We would actually would like to try this on as well.
Yeah. Yeah, exactly. But still, I think that is why it gets so confusing. So we really need to dissect the biology and the clinical phenotypes, as we are doing for Kabuki syndrome, for example. It's a different syndrome. There's overlap, but more on the biology side than on the clinical side. So for parents, it's confusing, I understand. But it's a syndrome that we carefully follow as well.
And may I just say, for those families here who are in that group, the KMT 5C group, we do collaborate with Dr. Banker in Manchester. And if you feel, you want to engage in a community and you sort of feel you want to find something that would fit, then we'd be happy to help get you in touch with Dr. Banker.
Yeah, that's where we're collaborating with Dr. Banker in Manchester.
Great. So I think a big topic in everybody's mind is regression. And there are a set of questions surrounding regression. One, wanting to know how prevalent it is. Does everybody with KS have a regression at some point? Two, are there things that you can do to help prevent its onset? We know we've heard a lot about olanzapine here today. And essentially, what can you do to try to buffer yourself for this period as much as possible?
Yes.
I think I can. Yeah, I was trying to unmute my microphone. I think I can address some of these questions. So, if you mentioned how prevalent is the whole regression part of this story, well, in fact, we do not exactly know how big the percentage is of the people that go into regression, that experience those kind of problems. We know that is probably not everyone that will have those kind of problems, and we don't know if and of course there will be a difference in severity as well. But there's because it's a relatively new disorder, and we only have started research on this just since a couple of years. There's a lot of information still to be gathered, especially around those regression periods. So our guesses our educated guesses are that there is indeed a significant amount of people that go into this kind of regression. That's why we have to take these kinds of issues quite seriously. But again, severity and occurrence, we don't know how those are exactly. And there was I think it was a second question. I wrote it down quickly, and it was about the preventing the onset. It's one of the things that's that we are interested in as well. It's I feel like I'm sort of repeating myself, but in this case, it's also the same. We do not know exactly the exact ways how to prevent these kinds of issues, but we do know that there are some sort of clues that might point to might come before a period of regression, and that is I mentioned those. So decline in sleep, a change of behavior, a loss of function in some way or another, and just behavioral changes that you can be quite that are very important to notice. So these can be reduced social skills. So if your child normally is quite sociable, if it comes to you and or wants to cuddle or that kind of stuff, and now sort of just wants to stay in his or her room and to socially block him or herself from any outputs from outside, that can be one of those things that you have to be aware of. So I think early intervention is one of the main things that we are focusing on. And how to prevent it? Well, it's quite difficult. So I would say we have to be busy looking at that as well. But how to prevent? We do not at the moment do not have the opportunities for that. And
it's part of the studies that we presented, also in line with what Joyce and Tanette showed. That we really look now for aspects in puberty life, what triggers
and there was I think a third part of third question. I've sort of forgotten it. Could you repeat that, please?
I think it's the relationship to puberty as well.
Oh yeah, as well, because there are as I mentioned earlier, is that there seems to be some sort of correlation between this start of regression, these psychotic episodes that may or may not occur, and some sort of hormonal stress. This can be just stress by daily life, or even I've encountered sometimes as well in a couple of instances that one of the patients with Kleefstra syndrome was in love with someone, and that love was unanswered. So the other person wasn't in love with the patient with Kleefstra syndrome. So that caused a lot of emotional stress as well. So in that case, and this led to a period of regression of a psychotic episode. So those are one of the things that might trigger such an episode. And also important to say is that a lot of people with Kleefstra syndrome have traits of autism, and of course that as you may know, that if people with Kleefstra syndrome adhere to a strict routine, that everything goes fine. But if something changes, like people, if they move out, or if their whole environment changes, their routine changes, this can cause a lot of stress as well. And I see something in the chat with about on COVID. Yeah, we're living in a pandemic right now, and this can cause a lot of changes as well. And I've seen that in the group I'm assessing as well, that in some cases this whole pandemic can be quite detrimental to the mental health of the patients. On the other hand, I would also like to say there are a few cases I know that that in which the whole pandemic has been sort of beneficial, because there was one patient with Kleefstra syndrome who went to school and got asked maybe the whole school experience was a bit too stressful for the patient, and after the school sort of closed down because of the COVID pandemic, the patient was most of the time at home, and therefore a lot less input, for a lot less stress from outside, and so the person was sort of recovering from that as well. So it can be beneficial, but the whole routine that gets broken, it can be quite stressful. Yeah.
Great. I think we're going to go to our audience, and there is a question from Caroline. Let's see if I can. Can someone give her access to speak?
Margot, are you able to open the microphone up to Caroline?
Hello?
Hi, Caroline, we can hear you. Would you like to read?
Oh, okay, wonderful. I have a daughter who's 15, and we just got our Kleefstra Syndrome diagnosis in November. So she's grown up with multi-diagnoses, but never had any kind of connection to all of them. My question with Kleefstra Syndrome specific to hypotonia is my daughter has an extremely high pain threshold. And because she's also on the autism spectrum with intellectual disability, sometimes there's a communication barrier, but she just does not seem to register pain to the point where she can't, we don't always know if there's something wrong. So she's actually dislocated and fractured fingers without expressing anything, or she had a UTI and wasn't able to communicate what was going on. So is there a connection there anywhere?
Perhaps I can chime in, and if others want to add, they can add as well. So decreased pain threshold is something that we see. I guess one question I had is, does your daughter have a diagnosis of autism? Did I hear that
Yes,
correctly?
she does.
Yeah. Decreased pain threshold is something that is seen commonly in autism, just generally speaking. So once again, not specific to Kleefstra, but in autism, in individuals with autism, we see that finding again and again. And it's sometimes dramatic to the point where some individuals can incur injuries and have issues such as fractures that are undetected because of that pain threshold. And the basis for that, I think, is still under investigation. It's not quite clear in a heterogeneous autism population. People have speculated various mechanisms for that, whether it's related to the peripheral nerve system or if it's related to a sensory processing defect or some other mechanism. So I guess, I guess it's hard to say, is that something that is specific to Kleefstra syndrome versus is it something that's part of the autism presentation that we see in autism populations. But I guess either way, I think we don't have a great grasp, I think, in terms of understanding the reasons why, and it can be a very, very challenging situation.
Thank you.
Great. Could we give access to, I apologize, Matolshi Sraja? Go ahead.
Yes, please. Can you hear me?
Yes, we can.
I just have a question about frame shift mutation, because that's a very special type of mutation. And it seems to me that the individuals with frame shift mutations are least affected by development issues. Is there any research on that? Or any explanation why that would be?
Can I ask you how you came to this hypothesis?
Well, yeah, okay. This is not a scientific hypothesis. I'm just scrolling the Facebook pages and see parents post different development milestones of children, and it looks to me that there are at least 2 or 3 that I know of who perform very well, and I was wondering what, I mean, I never knew about this frame shift mutation, and now I read about it. I seem to understand it, and it looked to me that they perform better, and I just maybe I'm wrong, but.
Yeah, I think so far we have no indications for that. So the majority of the patients do have frame shift mutations, so it's really common. And frameshift mutations mean that there is a difference in the reading frame of the gene, and it will probably be, the transcript will probably be degraded because of the shortness of the transcript, and the cell will recognize it is incorrect. So it will lead to this loss of one allele that was nicely presented. So we have no indications that this is that the individuals with frame shifts, but frame shifts might be scattered throughout the protein to the gene. So it can be at the start of the gene, or in the end, or in the middle. So it is very heterogeneous.
Mm-hmm. Okay, thank you. I was just wondering. Thank you very much.
Yeah.
Could we give the microphone to Bill Seal next? Go ahead, Bill.
Bill, your microphone is muted.
Okay. I was hoping somebody could tell me whether there's any research being done on the application of CRISPR technology, specifically with respect to Kleefstra. It seems like it would be a promising area of research. Hello?
Anyone want to take a stab at that question? Perhaps Dr. Khazri?
Yeah, I think that well, I'm not aware immediately that someone is working on CRISPR for Kleefstra per se, but of course it, as was explained today, is a very powerful technology. The difficulty always is to see how you would use CRISPR in this case, because you would need to what we want to do is restore a copy of the gene. So there are actually I think so there are ways to direct, for example, to use the CRISPR technology to direct transcription factors to increase the expression of the healthy allele. So I think those are technologies that are being done for other genes, but I'm not aware for EHMT1 itself. We are using more an mRNA approach to increase the mRNA stability. So I think all in all, there are not many genetic strategies, and I think that we'll probably have to see how this works best. And in that sense, I think the stem cells are a very nice model system, because probably, or there's a possibility that for each individual mutation or type of mutation, one needs to design another strategy. And so working directly with the cells from the patient for a specific individual is a big advantage for that. So yeah, so that I don't know if Liz knows about, or maybe that they are doing some CRISPR strategies at this moment. Not sure.
Yeah, the CRISPR work that we're doing right now is mostly in iPSCs and iPSC-derived neurons, so not in patients themselves. And mostly we're trying to use this technology to narrow down exactly what genes or what mutations are responsible for the mutations that we see in the neurons. So when we correct a specific mutation, do we see a reversal of the phenotype in the dish? So not quite getting to the point of applying to into the clinic, but just for us to better understand the biology of the mutations.
I think, Maya, do we have time for one last question?
Yeah, I think we could. Yeah, we do.
Great.
Go ahead.
So let's give Karen the microphone.
Hello.
Hi, Karen. We can hear you.
Hi, everyone. This question seems rather simple compared to the others, but I'll ask it anyway. As constipation and GI issues are often a challenge for our loved ones, in this case, our son, who just turned 5, we have a wonderful pediatrician. She recommended Miralax for that on a daily basis, and I'm just read lots of different things about the safety. It's also known as PEG 3350. I've read that it's not indicated for children, yet it's prescribed off label. I've just heard so many conflicting things. We also tried to feed him something with ground flaxseed daily. He drinks tons of water. In fact, he'll only drink water. But if he's not pooping, he's not happy. So we give him like a quarter of the recommended dose twice daily. And I'm just wondering, is this safe, or do I really need to explore other options for him to help the bowels flow and have those regular bowel movements daily?
Maybe I can comment on that, because I'm a pediatrician and I see a lot of children with neurodevelopmental problems, and also, of course, Kleefstra syndrome. And I think almost 80 or 90% from these children, especially at a young age, they have constipation. I don't know the medication you mentioned, because in the Netherlands we use Macrogol. That's the medication I often prescribe, and this works wonderfully in children and has really low side effects. I don't know if Dr. Sid maybe has experience with treating constipation in the United States.
Yeah, I guess to answer, I guess your specific, I guess the question about Miralax is that I understand concerns. I think there's I guess what I should say is that there can be many reasons for the constipation, right? So hypotonia can be a contributing factor, or low muscle tone. And as was mentioned, constipation is a very common problem in this population. In the States, we do, Miralax is used. I guess I don't have enough experience to kind of comment about the specific concerns about the pegylated, the ethylene glycol, the component in that. And yeah, so I guess I'm not entirely sure about specifically for Miralax, but often, for kids who have refractory constipation, we'll often send them to GI to have bowel cleanouts done, because sometimes you can end up in a cycle where if you don't control the constipation, then that can affect the behaviors, and it just can turn into a really difficult cycle. But I don't have enough experience to comment about Miralax specifically.
Okay, thank you. That's helpful. I would be curious if someone could post the name of the medication used in the Netherlands, just so I could see the difference, in what the active ingredient is. And of course, we try to treat it dietary wise, lots of water, like I said. But I just want to do what's safe, but I also know that it's not safe for him if he doesn't have a bowel movement daily. It's uncomfortable for him. Thank you, Joost, for sharing that.
Thank you all for your questions. Just so you know that we will prepare a document with all the questions that you guys have posed and their answers from the Q&A over the course of this meeting, and we will collate that and share that with you all at the end of the meeting. So I will turn it over to Dr. Chopra. Let me stop my share. Thank you.